Welcome back to the pharmacotherapy series on Pharma palette. In the previous video, we discussed the basics till the diagnosis of hypertension. Now comes the most important part, the treatment and pharmacotherapy. Which drugs are first line? When should we start one drug or two drugs? How should we choose the right antihypertensive for a patient? In this video, I will simplify the complete pharmacotherapy of hypertension in a very easy and understandable way for Pharm D PB, and all other healthcare students. So let's get started. So coming back to the goals of the treatment. So in the hypertension, first goal is to reduce the morbidity and mortality. Morbidity is reducing the hypertensive complications. Reducing mortality means it is reducing the death which is caused by the hypertensive complications. So and also you need to reduce some other complications like kidney injury, stroke, heart attack conditions need to be reduced. And the next one is the non-pharmacological therapy. Especially if the patient has the hypertension, some lifestyle modifications will be preferred. In that, first one is weight loss. Especially if the patient is obese, weight loss should be given. Second thing is following the DASH diet. It is simply the dietary approach to stop hypertension. So this diet mostly includes the vegetables, fruits and other low fat dairy contents, and this avoids lot of oily and junk food. And the next one is to reduce the salt intake. The usual salt intake for a day should be 1.5 grams, not more than this. And the next one is the physical activity. So 90 to 150 minutes per week the physical activity is necessary. And next thing is to reduce the alcohol intake and to stop the smoking, especially if the patients are having mild BP and if they are having low CV risk. At that conditions the lifestyle modifications would be enough to treat the hypertension. But even after doing this lifestyle modifications, if the BP still remains high, at that condition the medications will be added. Coming back to the pharmacological therapy, so the general approach to this treatment is usually the treatment of hypertension will be based on how high the BP is and its complications. So stage 1 hypertension we will be giving one drug. In stage 2 hypertension we give two drugs, and these drugs will be preferred from the first line agents only. In the hypertension case, the first line drugs, to remember the trick as ACT. A means it is angiotensin converting enzyme inhibitors. So the examples like captopril, enalapril will be given in this. And next A means it is angiotensin receptor blockers like losartan, telmisartan will be given. And C means calcium channel blockers, amlodipine, nifedipine, verapamil, diltiazem will be given. And the last one is T, which is thiazide diuretics. Hydrochlorothiazide, chlorthalidone will be given. And there are some other drugs like beta blockers, like atenolol. These are usually not the first choice of drugs, but still they are given if the patient has any kind of heart failure or heart disease. And there are some other drugs like alpha blockers, direct renin inhibitors, central alpha 2 agonist, and direct vasodilators. These are usually less preferred because they are having more side effects. These other drugs are usually given in order to treat the resistant hypertension. So coming back to the treatment algorithm of hypertension, usually if you see, you already know the stages. There is normal BP, elevated BP, stage 1 and stage 2. So in the normal BP, if it is less than 120 by 80, you will be simply going for the lifestyle modifications because it is just normal. And next one is the elevated BP. So if there is a slight increase in the BP, here also lifestyle modifications will be preferred, and then you will be rechecking for again 3 to 6 months. After then coming to stage 1 hypertension, here you will be checking does the patient have any other complications like CKD, diabetes, CV risk and all. And if we do not have any complications, if the patient don't have any conditions like diabetes, CKD and CV risk, then you will simply go for the lifestyle modifications and you will recheck after 3 to 6 months. Then if the patient, yes, if he is having any kind of the diseases like CKD, diabetes or CV risk, you will be performing the lifestyle modifications. Along with that, medications will be provided to the patient. In the medications, in the stage 1 hypertension, only one drug will be given. So monotherapy will be considered. So any one drug from the first line drugs will be given, and then you need to recheck this after 1 month. Coming to the stage 2 hypertension, here lifestyle modifications along with that medications will be added, like more than one drug. Two drugs will be given in this. So you'll be checking if there is no compelling indications. What is compelling indication? If there is no specific disease, so that is called as no compelling indications. So here two drug combination will be given. So you will be giving either ACE inhibitors or ARBs. Along with that, you will be adding the CCBs, calcium channel blockers, and thiazide diuretics. Then after adding this, you will be rechecking this after 1 month. So you will never give ACE inhibitors and ARBs together because they increase the side effect. Let's discuss about each first line agents. So the first line drugs are the angiotensin converting enzyme inhibitors. So these drugs will be usually ending with the term pril. So any drug, if it is ending with the term pril, comes under this angiotensin converting enzyme inhibitors. So these drugs usually act by inhibiting the conversion of this angiotensin 1 to angiotensin 2. So this ACE inhibitors will block the conversion of angiotensin 1 to angiotensin 2, due to which it leads to the effects like it decreases the vasoconstriction, it reduces the aldosterone secretion, and also increases the bradykinin, due to which it results in the conditions like, because of decreased vasoconstriction, it leads to vasodilation, decrease in the blood pressure, and also it reduces the sodium water retention in the body. This angiotensin converting enzymes are usually started with the low dose. Then there will be dose titration will be performed where the dose is slowly increased, because if there is sudden increase, it leads to acute hypotension in patients. To prevent that, slow increase of doses preferred. And coming to the side effects, so dry cough is one of the most important side effects in this ACE inhibitors. This is usually causing because of increased bradykinin. Because of increased bradykinin, dry cough will be occurring. And next one is hyperkalemia. Usually increase in the potassium levels will occur. And next one is hypotension. We already saw if the dose has increased, that leads to acute hypotension in the elderly patients. Next thing is AKI, acute kidney injury, and angioedema. So angioedema is very rarely seen in less than 1% of the patients. And at that condition, if angioedema occurs, drug withdrawal can be performed. And next thing is, there are some kidney effects, like there will be slight increase in the creatinine levels will be seen initially, and also there will be a condition called as renal artery stenosis increases this AKI risk. Coming back to the contraindications, this ACE inhibitors are not preferred in the pregnancy, and it is not preferred in the patients who are having the bilateral renal artery stenosis. And if the patients are having history of ACE inhibitor induced angioedema, this ACE inhibitors will not be preferred. Benazepril, fosinopril, lisinopril will be given at a dose of 10 to 40 mg per day. So coming back to the second class, which is angiotensin 2 receptor blockers. So coming to the mechanism of action, this usually the name itself states that they block angiotensin 2. Simply they will be blocking this AT1 receptors, due to which it will again result in the same conditions like vasodilation, decreased BP, and decreased sodium water retention. Apart from that, there will be decrease in the aldosterone here. The only difference between the first class and the second class is this angiotensin receptor blockers will not increase the bradykinin, due to which the chances of getting the cough and the angioedema will be less. And coming to the side effects, it will be again having the hyperkalemia, hypotension, angioedema. It occurs, but it is very rare. Coming to the contraindications, it is not preferred in the pregnancy and also in case of lateral RAS, which is renal artery stenosis. And also in this condition, we will be monitoring the conditions like potassium levels, serum potassium levels, BP, and the kidney function will be checked. So coming to the examples under this angiotensin 2 receptor blockers, one is telmisartan and olmesartan. Telmisartan is given at a dose of 20 to 40 mg per day. Olmesartan is given at a dose of 20 to 80 mg per day. So coming back to the third class, which is calcium channel blockers. These are usually of two types. One is dihydropyridines and non-dihydropyridines. The only difference between this is the dihydropyridines will be acting on the blood vessels, whereas the non-dihydropyridines will be acting on the heart. So coming to the examples, in the dihydropyridines, amlodipine 2.5 to 10 mg per day can be given. In non-dihydropyridines, diltiazem extended release 1 can be given at a dose of 180 to 480 mg per day. So coming back to the side effects of this dihydropyridines, so just remember HPRFD, where H means it is headache, P means peripheral edema, R means reflex tachycardia, F means it is flushing. Flushing is simply the red face. D means it is dizziness. So coming back to the side effects of non-dihydropyridines, remember the trick as H cap. H means it is heart failure worsening. C means constipation can be seen, but it is seen with the drug verapamil. And A means it is AV block, B means it is bradycardia. Coming back to the mechanism, both the classes, both the types will be blocking the calcium channel blockers, but the only difference is the dihydropyridines will be blocking calcium channels, due to which it will be acting on the blood vessels, thereby causes the vasodilation, then the BP will be reduced. Non-dihydropyridines will be acting on the heart, due to which it reduces the heart rate, reduces the AV conduction, and reduces the cardiac workload. And these drugs, calcium channel blockers, are usually given to treat hypertension, angina, and arrhythmias. So coming back to the last class under this pharmacological therapy of first line drugs, this one is diuretics. So the mechanism of diuretics is that it will be removing the water and sodium from the body, due to which the blood volume will be reduced, and that leads to the decrease in the cardiac output, which finally reduces the BP. So these diuretics are usually of three different classes can be used. One is thiazide diuretics, loop diuretics, and potassium sparing diuretics. Thiazide diuretics are the first line drugs which will be preferred. In that, especially the chlorthalidone is one of the potent one, which is usually given at a dose of 12.5 to 25 mg per day. And the side effects in this are hyperglycemia, hyperuricemia, and hypokalemia. And coming to the second class, which is loop diuretics, here the drugs like furosemide can be given at a dose of 20 to 80 mg per day. In the loop diuretics, the side effects can be hypokalemia, hypocalcemia, and dehydration. And the last one is potassium sparing diuretics. Here the drugs like spironolactone, iplerenone can be preferred, and that too at a dose of 80 to 100 mg per day. And here the side effect is hyperkalemia. And if these diuretics are used for the very long period of time, this can also reduce the peripheral vascular resistance. And coming to this loop diuretics, this will be causing the strong diuresis. This is usually loop diuretics are preferred in case of edema and CKD conditions, especially if the patient has any kind of heart failure. So coming to this potassium sparing diuretics, these are especially used in case of resistant hypertension. This will be preventing the potassium loss from the body. And this is also given by combination of thiazide or loop diuretics, potassium sparing ones. So coming back to the other alternative antihypertensive agents, so beta blockers will be preferred, especially for treating the compelling indications. These are the first line drugs. So compelling indications means it is a specific disease. And next thing, other drugs like alpha 1 blockers like prazosin, doxazosin, direct renin inhibitors like aliskiren, vasodilators like minoxidil can also be used in this hypertension treatment. And coming back to the last part, which is the evaluation of the therapeutic outcomes. So initially you will be checking for the BP, then you'll further do the follow up, monitoring of various adverse drug reactions. Then again you'll see the laboratory monitoring. You will be monitoring the symptoms of hypertension complications, etc. will be done. And now let's see what are some certain hypertensive emergency drugs. So in this, just remember the trick as NNL, NH. So to see the hypertensive emergency drugs, N means it is nitroprusside. This is usually given in case of immediate action. Second one is nicardipine. This is usually a common IV antihypertensive drug. And next is L, which is labetalol. This is the common emergency drug in hypertension. Next one is nitroglycerin. So this is used especially in case of cardiac patients. Then we have H, which is hydralazine. This is mostly given in case of pregnancy hypertension. So that was the simplified pharmacotherapy and treatment algorithm of hypertension. I hope this video made the topic easier to understand and remember. Keep learning consistently. Even one concept a day can make a huge difference in your clinical understanding. If this video helped you, don't forget to like, share, and subscribe to Pharma Palette. And don't miss this pharmacotherapy series. And in the next video, we will enter into another important cardiovascular topic, which is the congestive cardiac failure. So stay tuned.